Hi everybody, I'm back and this week I'm going to talk to you about Irritable Bowel Syndrome, or IBS as it's known for short. So IBS is a really common gut disorder. It's characterised by a real variation in symptoms that's unique to every patient. We don't know what the cause is, and the only thing we do know is that when we examine the gut wall via a biopsy, look at it under a microscope, there are no changes to the gut wall. So it differentiates itself from inflammatory bowel disease in that way. We don't know the causes for sure, but there are lots of suggestions. And we certainly don't have a cure as of yet, but there are solutions and things being researched all of the time for the future that are quite promising. I said it was common. It affects 1 in 5 people, so that's 20% of the population. So it really is a massive problem for lots of people. Usually it's a disease that's diagnosed before you're 35, and it's certainly very unusual to diagnose it in somebody that's over 50. There are slightly more women that suffer from it, but it's not a massive difference, it's very slight. We do know that on average people don't get a diagnosis for 4 years from when it starts, and along that time they can be really poorly treated and really suffering with symptoms. So it's very frustrating and debilitating. So these symptoms that cause such problems, the list is vast, but to give you an idea, abdominal pain and bloating are really common and quite often are interspersed with either constipation or diarrhoea or both. Quite often the symptoms of pain and bloating get better when you've opened your bowels or had a poo. People can quite often feel that when they have opened their bowels that they still haven't quite emptied them, and that's called tenesmus. They quite often have frequency, so they're going more often, and urgency, so they really need to go now. There can be nausea alongside that bloating, and then lots of other symptoms that are associated with it, like being full really quickly when you eat a meal, having no appetite at all, having heartburn, tiredness, belching and burping, muscle pain, and even something as like irritable bladder. So you've got an irritable bowel and alongside that an irritable bladder as well. So basically the whole pelvic area is upset in IBS. These symptoms wax and wane, so they go up and down, and some patients can go really long periods of time with no symptoms at all, but some patients have symptoms all of the time that don't ever get better. Medical professionals, me for example, tend to group people suffering from IBS into 3 different areas, and the only reason we do that, and they're very broad areas, is to try and guide the treatment protocol, because depending on what your symptoms are will depend on what treatments work for you. So those groups very broadly are abdominal pain, bloating and constipation, abdominal pain, diarrhoea and urgency, or alternating between those 2 groups. My experience is that every patient is very different, and rather than grouping people, I just listen to their symptoms and work with them to find a treatment that works. A really important thing is that blood is not a symptom of IBS. And when I say blood, I mean blood in your poo. So if you're passing blood from your back passage, you need to see a doctor, come what may, because it isn't a symptom of IBS, so you can't make that assumption. If your IBS is predominated by constipation and you've got hemorrhoids or a fissure, then you may have blood, but it isn't a symptom of the IBS. So I mentioned that we weren't really sure what the cause was, but there are lots and lots of suggestions and ideas. It's not clear for sure, but we think that there might be areas of gut that for whatever reason are overactive. Now it could be that the nerves supplying that part of the gut are too active, but we're not sure why. Certainly there seems to be an association with food and food intolerances, and I'll come on to those. There also seems to be quite a clear connection with an infection of the gut, so a bacterial infection, because if somebody gets a bacterial infection or a gastroenteritis, they are 7 times more likely to get IBS. So something happens when you get a bacteria in the gut that shouldn't be there, and we think that it probably interferes with the normal gut microbiome, the good bacteria in the gut, and that affects the permeability of the bowel, how well it absorbs, the immune activity that goes on in the walls of the bowel, the sensory system or the enteric nervous system which supplies the gut somehow gets interrupted by this. So definitely gut microbiome is really important. And we know, for example, in mice, if we remove the gut microbiome, they become much more pain sensitive. And this could be happening when there's a bacterial overgrowth or disruption in the bowel, so that you're feeling pain more than you would normally from the bowel. So that's another idea that's being studied, and I'll put details of that in the description afterwards so that you can have a look at it. We know that if you've got bile acid malabsorption, that can be associated with IBS. That there is another suggestion, another study that suggests that your T-cell immune system can be exhausted. So if you're constantly stressed or anxious and your cortisol levels are really high, this can actually wear out the immune system, which then has a detrimental effect on the gut because the immune system isn't doing the job it should be doing in the gut. So again, I'll put that study in the description afterwards. We know that anxiety plays a role, that when people are more anxious and they have IBS, that their IBS symptoms get worse. We also know people who don't have IBS, when they get upset or stressed, can get diarrhoea. So certainly there's a massive connection between emotions, anxiety and gut reaction. So those are just some of the suggestions for causes for IBS. Why is it important? Well, it affects lots of people and it can be absolutely debilitating. The pain itself can be debilitating so that you can't function or do anything. The symptoms can be really embarrassing, you know, frequency and urgency, diarrhoea, bloating, not being able to eat a full meal. So they can have a massive effect on life. So much so that people stop planning. They stop planning on going to social events, the cinema, on a flight, sometimes to work. So a massive effect on day-to-day function. We know that so much so that people's careers can be interrupted or held back because they're having time off work, they're missing promotions. People are judging them in a certain way, which is wrong, obviously. All of these symptoms can cause depression, and it's really difficult to unpick whether the depression itself is being caused by the symptoms or whether it's making the symptoms worse, and it's probably a bit of both. But certainly depression is a major thing to consider when I'm dealing with a patient with IBS. Personal relationships can be affected and disrupted, so either you can't make personal relationships because the symptoms are just too embarrassing and you're not going out and meeting people, or the relationships that you have are being affected because you're so ill and so unwell. So all of this together has a profound effect on function and the ability to take part in life and ultimately on quality of life. We know that it has a massive effect on productivity and there's a massive healthcare cost. So IBS is a really important disease that we need to know more about and we need to be able to treat really well. It's such a big problem that there are lots of IBS support groups, charities focusing on the illness and research, Facebook groups, and I will list some of these in the description afterwards because they may really help. So how do we diagnose it? Well, it's really a clinical diagnosis. So as a GP, I will listen to people's description of their symptoms and can make a diagnosis, certainly a working diagnosis of IBS. I never leave it there. I always do more tests because the symptoms of IBS cross over with lots of other diseases and illness processes, and it's important to make sure that we're on the right track. So I always do blood tests, a full blood count to make sure that absorption's taking place properly, an ESR to make sure there's no inflammation going on, celiac test to make sure it's not celiac disease, and if it's a woman, a CA125 to make sure it's not ovarian cancer. Then I'll do stool samples, so more poo I'm afraid, for fecal calprotectin, which is a really sensitive test that tells us whether there is or isn't inflammation in the bowel. And it's really reassuring for us if we're thinking IBS and that test comes back as negative, because then we know we're on the right track. Then I would look for Helicobacter pylori, which is a bacteria that lives in the stomach and can cause reflux, gastritis, heartburn. It can be really easily treated. So again, differentiating it from IBS and treating it as necessary. It's really rare for somebody to need to have a camera endoscopy that goes down and looks at the stomach and goes up the back passage to look at the bowel. But if, for example, we had somebody who was over 50 and they were presenting with symptoms of IBS, we probably would do that because it's very rare to diagnose IBS in somebody who's over 50. But other than that, it's really unusual. So how do we treat it? Well, it's a combination of things as always, starting with lifestyle. So in terms of lifestyle, I think it's always great to keep a symptom diary for a little while. So you just write down what's going on in life, whether you're at work, at home, any anxiety or stressors, what you're eating, drinking, anything new that's going on, any medication, and what your symptoms are so that we can track it and see if there are any particular triggers. Particularly useful before and after a new treatment to see how well it's worked. Exercise always works well, as we know, does for most things. And managing stress, because we know that stress impacts IBS. So whatever you need to do to manage your stress, and again, everybody's individual. For me it's gardening and acupuncture, but for someone else it might be reading or yoga. It doesn't matter what it is. If it works for you, try and manage stress. Then in terms of diet, we know that certain foods will trigger IBS, and it's probably different for everybody. But certainly some of the advice I give is to keep regular meals and eat slowly. Don't skip meals if you can help it. Drink plenty of fluid, so 8 cups of water a day. Try and limit alcohol, limit caffeine, limit fresh fruit to 3 pieces a day. And if you have diarrhea as your predominant feature, avoid things that have got sweetness in them. So sorbitol, for example, really does increase pain and diarrhea even if you haven't got IBS, so avoid that. And if you've got wind or bloating, eat more oats and add some linseed to try and help those symptoms. The advice on fibre and IBS changes all of the time, but there's certainly a connection. Fibre stays in the gut and doesn't get absorbed, so it helps build your stool so that it's nice and soft, ready for you to actually open your bowels and get rid of it. Studies are mixed, as I said, and it really does depend on what your predominant symptoms are. So if you've got constipation, then yes, a high fibre diet's a good idea. If you've got diarrhea, it's a bad idea. The type of fibre is important, and the type of fibre you want if you're going to eat a higher fibre diet is definitely soluble fibre. So that includes things like oats, some fruits, but you need to be careful. Pears are quite good, strawberries, not apples. Pectins, nuts and seeds, they will all help. The kind of food that you want to avoid is not soluble fibre, so insoluble fibre, and that includes things like bran, corn, apples as I mentioned, wheat bran. They're not good for IBS, they cause bloating. Then there's the Low Fodmap diet, that's FODMAP. That stands for fermentable oligosaccharides, disaccharides, monosaccharides and polyols. In other words, carbohydrates. So the Low Fodmap diet is absolutely massive. I'm going to put a link to it below, but when you look and if you know it, the foods on it cover almost everything. So I always say to patients, do not follow the Fodmap diet because you'll never eat again and you'll lose too much weight. Probably cure the IBS, but it's not much good for anything else. So the way I use Fodmap, and it is useful, is I say to patients, go through Fodmap, have a look if there's anything on there that you're eating lots of, and then try and cut that out. But do it one thing at a time so that you know what it is that's irritating you and if it works. And from that perspective, it's a really good idea. We know that food intolerances definitely have a role. They probably increase fermentation in the gut, so causing lots more wind and pain as a result. The kind of foods that we know often people find that they're intolerant to when they have IBS, definitely onions and dairy, wheat, rye, barley and caffeine. So you might try cutting those out, but again, one at a time so that you know which one works for you, if any of them do. We've mentioned the gut microbiome, and definitely there's a role to play here for good bacteria helping IBS, but we don't know at the moment what bacteria. Lactobacillus again has been mentioned as one of the bacteria that might help and might be missing in people with IBS. So if you're going to try a probiotic, and they do sell them, there are capsules for example, or there are foods that have probiotics in them, do it one at a time and try it for a month so that you've got a good build-up of the bacteria and see if it helps. And if it doesn't help, by all means switch to another one and try that, because your need might be different to somebody else's. Always use the same brand on that month trial as well, because otherwise you don't know how much you're getting. Now on to medication. So pain is the first thing that we try and control, and we do that with antispasmodics, so medications that stop the bowel from contracting and causing pain. So the kind of drugs that we use for this you may have heard of already, so mebeverine, hyoscine, peppermint oil. And you might find that one works for you much better than another, and it's mix and match time or just trial and error and find the one or the combination of that works well for you. Constipation can be a big problem for people, really uncomfortable. So whilst we don't go straight to laxatives, because it's always good initially to try and increase your insoluble fibre to help, if that doesn't help, and to be honest quite often it doesn't because it's quite difficult to get enough fibre, we do add in laxatives, but we try and use fibre-based laxatives like fibre gel, which is Isfagula husk, and never use lactulose in IBS because it's fermenting and it can make things much worse. There's another drug called linaclotide, and it is licensed for IBS, and it increases fluid in your gut, which helps soften poo and make getting it out easier. And that's just once a day, and it eases pain and bloating and constipation. So worth talking to your doctor about that one. For diarrhea, we use loperamide, which you'll know over the counter as Imodium. And ondansetron has been shown to work with bloating and urgency, and that's actually an anti-nausea tablet. Peppermint oil again works really well for bloating. I had someone today tell me how well it had worked. And then sometimes we can use antidepressants, but not for depression. We use a tricyclic antidepressant called amitriptyline, which is best for pain and diarrhea, and it just seems to help the pain that comes from that problem with IBS. Sometimes we use an SSRI like sertraline or citalopram, and we think that that alters the way that pain is experienced. So I must admit I hardly ever use these for IBS, but it is there if nothing else is working to try. If you've got confirmed bile acid malabsorption, then a bile acid sequestrant that soaks up the bile acid can work quite well. Then I mentioned newer treatments, and I probably won't be able to say any of these, but I'm going to try. But I'll write them afterwards so that you can look them up. So for diarrhea, there is a medication called allosetron, and it blocks serotonin and it reduces diarrhea and pain. Then there's a medication which is an antibiotic called rifaximin, and it changes the bacteria balance in the gut, and we've already talked about that balance being a contributor to IBS. It reduces bloating and diarrhea. It's a 2-week course, and you get benefit for about 10 weeks. In constipation, there's a new medication called lubiprostone, which promotes secretion in the gut, and peristalsis, which is the rhythmic movements that the gut makes to move poo along it. So that just helps with constipation and getting it out. So those are the newer drugs, something to look for, and maybe talk to your doctor if you've run out of options on all of the traditional ones. I mentioned psychotherapy. I have to say there's little evidence for this, but we know that stress and anxiety plays a role in IBS, so if you can reduce those, theory goes that it might help with the symptoms. So in moderate to severe IBS, where all other treatments have failed, there's a suggestion that CBT, or cognitive behaviour therapy, might help, or even hypnotherapy, but as I said, there's not a lot of evidence for it. So in summary, IBS is a functional gut disease. It's really complex and debilitating. The symptoms are varied from person to person. They're not completely understood, the causes aren't understood, and there is no cure. But we do know the effect it has on people's life is devastating for some. More research is definitely needed and it is underway, and have a look in the description below for some pointers to some. We think the gut microbiome is definitely implicated, and I think that's really exciting because I think it holds out hope for the future for treatments. And there are lots of different treatments that I've listed, and it needs to be unique to you as a sufferer, and your GP should listen to you and work out with you and try with you different combinations, and don't give up. Just because one combination doesn't work doesn't mean another one won't work. So just keep trying and have a look at the FODMAP diet and see if there's anything that you can eliminate, and try that too. Essentially, don't suffer in silence because there's lots that can be done. Come forward, see your GP, and if you haven't got an answer, go back because there might be another solution. There might be some of the newer ones now. So I hope you've enjoyed this. It's a big topic again. Any questions that you've got, please ask me in the comments because I will answer all of them, I promise. Make suggestions for other topics in the future, and please subscribe. And thank you for listening, as always.